Hello everyone, welcome to the Lung Ultrasound seminar. We are going to get an overview of basic lung ultrasound features and not so basic applications of lung ultrasound. First of all, we need to consider a couple of things, a couple of lung ultrasound rules that are the base of this technique. Lung ultrasound number one rule is that almost 90% of what we are going to see is just unreal. It's not real, it's an artifact. And second is the air and fluid relationship. We are going to talk this later. Like in this Caravaggio painting, which is, by the way, courtesy of my friend Giovanni Volpicelli, we can see that there's a line, there's a limit, there's a border between reality, which is the upper part, the upper half of this painting, and the pure reflection, something which is not real. And this is the lower part of the picture. This represents perfectly what's the essence, what's the philosophy of lung ultrasound. In this example, the pleural line will be the border of our two images. The real images, which is supposed to be the superficial part of our screen, and the artifact, the unreal image, which is supposed to be below the pleural. Every single evaluation of the lung using ultrasound needs to start from the same point, which is the bad sign. The bad signs, we can evaluate the bad sign when we place the transducer perpendicular to two ribs in longitudinal, and this is the image we are gonna observe, in which the superficial part is the skin, the subcutaneous tissue. The next layer of tissue is muscle. We have two reflections, two hyperechoic structures with posterior shadowing, which are the ribs. And below the ribs, we can see a line that is the pleural line. In this case, from the pleural line to below, it's not real. This is the lung, contains mainly air. So the image we are looking at is not real. And the superficial part is totally real. The skin, the subcutaneous tissue, the muscle, even the cortical part of the ribs. The bad sign can be evaluated, like in this case, with a linear probe, or we can use either probes, like low frequency probes. Like in the image, the left screen, the left clip is the bad sign observed with a linear probe. The second one is the same image with a curvilinear probe. And the third one can be difficult to assess the ribs because we are using a phased array probe, which is specifically designed to avoid ribs. So anyway, there's different images for the same bad sign. The pleural movement, it's really important to assess because the kind and the type of pleural movement are going to give us crucial information about one, the relationship between both layers of pleura, the visceral and the parietal part, and the physiological relationship between them. The second, the ventilation status. If this part of the lung we're evaluating is or not ventilated. So the first kind of movement, the first type of movement is the normal one, the lung sliding. If you take a look at the pleural line, there's a sliding or gliding movement, a back and forth movement. This means that both layers of pleura are physiologically attached, and this area to be evaluating the back and forth movement is normally ventilated. So if these two conditions are normal, we can totally rule out a pneumothorax with 100% of sensitivity. And what if both layers of pleura are physiologically attached, I mean normally attached, but this area of the lung is not ventilated? We'll observe this pattern of movement. So take a look at the pleura. The pleural line is moving, but this kind of movement is not a back and forth movement. It's a pulsation. This is called lung pulse. What's this pulsation, by the way? The pulsation you are actually observing is the mechanical impact, the mechanical energy of the heart contractions along the pleura. So, if you see while evaluating the pleura the lung pulse, this means that both layers of pleura are physiologically attached as well, but the particular area you are placing the probe is not ventilated. So take a look again. Okay, what if we separate both layers of pleura? I mean, what if the patient has a pneumothorax? Air between both layers of pleura. You will see this pattern of movement, no sliding. Actually, there's movement around the image. The muscles, the hand probably, because the patients with pneumothorax used to breathe like strongly, they're normal, but the pleura does not move at all. So the absence of sliding or no sliding is present in all kinds of pneumothoraces. The specificity is not perfect, but it's quite good as well. It's 96% of specificity. Because the absence of sliding, the no sliding, is present as well in pathologically attached pleuras. So another conditions that are not air between both layers of pleura, but both layers of pleura are pathologically attached. This is no sliding as well. So this is a pneumothorax. This is a non-complete pneumothorax. This is a non-tension pneumothorax. So there's a place between the air and the normal attaching pleuras. So if I put the probe here, I will see no sliding. If I put the probe down here, I will observe normal sliding. But what if I found this particular point in which the pleura starts to be detached? I will find this. The pattern alternates normal sliding in the left side of the screen and no sliding at the right side of the screen. And the transition point moves with the respiratory movements. Moves depends the inspiration and expiration of the patient. Finding this particular pattern, which is called the lung point, is 100% specific for pneumothorax. So let's take an overview of the patterns as well. So lung sliding, no sliding, lung pulse, lung point. The lung sliding is normal. So normal condition, no pneumothorax for sure, and the lung is normally ventilated. No sliding. No sliding is present in pneumothorax, but as well in another pathologically attached pleural conditions, like pleuritis, previous surgeries, or pleural diseases. The lung pulse means no pneumothorax for sure, but there's no ventilation at this point. So maybe respiratory arrest, maybe apnea, or maybe an early stage, a super early stage of atelectasis. The lung point, I told you before, is totally diagnostic for pneumothorax. Tips and tricks for evaluating pneumothorax and pleural movement, especially if you are looking for a pneumothorax. Take in mind the second rule of lung ultrasound, which is the air and fluid relationship. Air, a single drop of air will go to the less dependent area. So in a patient in supine position, you need to look at it anterior. It's much better if you use the linear probe, just looking at the pleural movement. We need this plus of definition. And the pleural is to be superficial, so it's not too deep at all. So scan in the anterior chest if you're looking for a pneumothorax. Now we will be able to assess conditions that happens below the pleura. I mean, parenchymal diseases, strictly lung diseases. But we need to assess two kinds of artifacts. The first one is the reverberation. Reverberation occurs when ultrasound beam crosses with really peculiar materials, like pure air in our case, or like in this case, in the picture you are looking at, is metal. The second are the comet tails. Comet tails that can be different depends of what is below the line. So comet tails occurs when the ultrasound beam crosses structures with two layers, like pleura or like peritoneum. So it depends what's below the pleura. You will find these tiny small comet tails like in the left clip, or the giant laser-like comet tails like in the right side of the screen. Ultrasound is a great densitometer. So again, we need to face the air and fluid relationship, because even the pathology in the lung and in the pleura plays with this air and fluid relationship. I mean, outside the lung, a condition with only air and no fluid, when I say fluid, I'm referring to parenchyma, vessels, a little bit of blood, or everything which is not pure air in the thorax. So a typical condition with pure air and no fluid at all is the pneumothorax. The opposite condition, which is totally fluid, the pleural space is totally covered, it's totally occupied by fluid, is the pleural effusion. But the parenchyma, the lung parenchyma, can be affected by this air and fluid relationship under a pathological point of view. So the normal relationship between air and fluid, which is mostly air and a little bit of fluid. Remember, the fluid is the parenchyma, the vessels, fluids, and so on. So it's the normal lung. Like in this case, this normal chest X-ray. When we increase the percentage, the ratio of fluid inside the parenchyma, we have edema. Edema, heart failure, pulmonary edema, all ranges of affection of this disease. If we increase in a particular area the air and fluid relationship towards the fluid, we will find the atelectasis. And if one particular area of the lung, we almost get out all the air and we put some fluid, in this case pus, cells, and so we'll find the pneumonia. We will able to find every single degree of the air and fluid relationship, not only outside of the lung in the pleural space, but in the parenchyma as well. But we need to assess the artifacts mainly. The basic artifacts. Basic one, number one, is the A line. We see the bad sign here with a curvilinear probe. We see the pleural line, and there's a reverberation. There's a multiplication of the pleural line towards the deeper part of the screen. Horizontal lines and the multiplication of it. While evaluating it with the linear probe, we can perfectly see that this is the normal pleural line, and this is the first reverberation, and this is the second reverberation. These reverberations are called A lines. And the translation of A lines is a reverberation artifact which indicates a dry lung. Dry lungs means that the air and fluid relationship of the lung parenchyma is towards the air. It's normal. This ratio is normal. It's much more air than fluid. When the interstitium begins to enlarge in terms of fluid or cells or inflammation, the comet tails that you are looking at in the screen begins to arise. These comet tail artifacts are called B lines and indicates interstitial inflammation. Although the real pathogenesis of the B lines is not yet known, not well known, we are supposing that in a normal interlobular septa, see, like in the scheme, the septum and the air, when the interlobular septa are thickened, the ultrasound beam is able to go deeper than normal and originates these B lines of a kind of a vertical lines compounded by millions of horizontal lines, like in this case. So the characteristics of B lines are this. They're well defined. They're starting from the pleural line, they move with the pleura, they erase A lines, so there's no E line, there are no E lines here, and reach the bottom of the screen without losing energy. So B lines indicates an affection of the parenchyma in terms of interstitial inflammation or interstitial edema, both can be. So a positive exam, we need to define what's a positive exam. The first one, the picture in the left, is giving us just one B line. The second one is giving us three B lines, and there are multiple B lines in the right image. So what's the positive and what's the negative? For sure, the right one is the one on the right is positive, but we are not sure what's the limit, what's the threshold for a positive exam, and it is at least having three B lines in a longitudinal approach in one intercostal space. We already know what's normal, what's not normal, and what's the threshold for a positive exam. But the key point is the distribution of these artifacts. Like in this example, we have a patient with shortness of breath, with dyspnea, and we are evaluating the lung with lung ultrasound. And we found this. A lines everywhere. Clinical possibilities. So the lung can be normal. The lung can be not normal, but the air and fluid relationship is towards the air, so asthma or COPD. A normal lung can be found as well in an early stage of pulmonary embolism. And we are just talking about A lines, not sliding. So a pneumothorax can be in the differential of our patient. Second case, shortness of breath, respiratory symptoms, A lines everywhere, but a small part of B lines. Pneumonia is one of the most important things we need to be included in the differential. Atelectasis as well. Lung contusion, or not an early stage of pulmonary embolism. So the patient can have developed lung infarction. A bilateral affectation of both lungs from base more to apex less affectation can be synonym to heart failure or pulmonary edema, but lung fibrosis can be the differential as well. ARDS and viral pneumonia has a kind of different pattern with B lines everywhere, with colliding B lines in a lot of places, but with normal lung into a non-gravitational and non-symmetric distribution. So tips and tricks, remember to scan different areas. And for assessing the pattern which is below the pleura, it's much better if you use the curvilinear probe. And how to differentiate, like in the second case, diseases which are totally different in between them, but with the same ultrasound pattern. Never use ultrasound, especially lung ultrasound, but any kind of point of care ultrasound in isolation. You need to combine a classical approach with a clinical information, with your clinical differential, with the image you obtain using lung ultrasound, and you will never miss a diagnosis. Consolidations. I told during the first slides that everything that you are looking at is not real, but in this case, it's not, because the consolidation is a real image. It's a real, it's an area which is totally full of materials, pus, cells, inflammation. There's no air at all, but it's only visible if the consolidation is in contact with the pleural. This is a pneumonia, which is the most frequent consolidation we see in clinical situations. So pneumonia is a ball of pus, cells, inflammation, but there's a halo around. If we put the probe here, what will we see? Nothing. We will see A lines because there's normal lung between the pleura, between the halo of interstitial affection and the consolidation. So we'll see nothing. Remember that A lines means artifacts. So nothing that you're looking at is real. It's just a reflection. If the halo of inflammation touches the pleura but not the consolidation, the halo of interstitial creates B lines, but there's no way to see below the B lines the consolidation, because B lines are artifacts as well. They're not real images. The only way to assess a consolidation, to see the real image, is if this consolidation touches the pleura. Like in this case, we can see in this intercostal space the consolidation and the transition between consolidation and non-aerated lung below. The last part of this lesson is the efficient. In some cases, we have to face with these situations in our daily practice. 2 chest x-rays with possibility of effusion, atelectasis, consolidation. So what's what? What is the left one? Can we use a needle to decompress the second one? So the use of ultrasound facilitates a lot of these kind of decisions. So the left one, you see the liver, there's a diaphragm, and above the diaphragm there's a lot of black stuff. This is fluid for sure. In the right clip we see something squeezing, probably is the heart, There's a line which is the diaphragm, but above the diaphragm, there's no fluid. There's something like a structure, like tissue. So this is consolidation. We can assess pleural effusions. We can easily identify the pleural effusion above the diaphragm. Like in this case, there's a lot of black fluid, and there's a consolidated lung. This is a atelectasis by compression. There's a compressive atelectasis of the lung, which is, in this case, there's not a normal pleural effusion. There are septations. Undoubtedly, there are septations here. So no matter if the clinical symptoms are against having a complicated effusion for the patient, we are actually looking at it. In the next slide, we are looking at multiple pockets of fluid which are separated between them, and even there's a solid area in the most superficial part. So probably in this case, just taking a look of this pleural effusion, we already know that it's complicated for sure. Probably the thoracentesis is not the first maneuver, the first thing we have to do to diagnose this patient. Both, almost all of them, can be not even possible to distinguish with a CT scan. So tips and tricks for the pleural effusion: go posterior. The fluid goes down. You need to go to the posterior part of the thorax, and this is related to the diaphragm. No matter if the patient is in supine position or is in upright position, the most dependent area of the thorax, the pleural space, is related to the diaphragm, both in left and right side. So thank you. Any kinds of suggestions, ideas, whatever you want or whatever you suggest, just don't hesitate to write to the email. Thank you.